Ask questions at the end of each case study by typing it into the chat box, and then Marianne or Leslie will read your questions. And please be advised, it is not the intent of this program or its speakers to provide clinical or legal advice. As you probably know, the Hospice and Palliative Care Nurses Association was established in 1986, and it's the national professional organization that represents the specialty of palliative nursing. HPNA supports professionals through education programs, research initiatives, and advocacy. And we continue to be very excited about our charter status, and we want to connect with you as we share our mission statement, which is to build an influential network of hospice and palliative care nurses and professionals in New Jersey to share tools, resources, and education focused on the provision of expert care of the seriously ill. The Northern New Jersey chapter is committed to educating and providing resources for all people without regard to race, religion, gender, gender identity, or gender expression, sexual orientation, national origin, disability, age, socioeconomic status, insurance, and educational background or beliefs. As a group, we acknowledge that we providers and our communities approach death with many diverse values and beliefs, opinions, and ideas on how we face and view the end of life. We embrace this diversity. We acknowledge and honor the fundamental value and dignity of all individuals, and we strive to create an environment that is equitable, inclusive, and provides a sense of belonging. I'd also like to add that we invite all disciplines, social workers, chaplains, doulas, LPNs, home health aides, to join our chapter, volunteers as well. The cost for a one-year membership is $25. So please consider joining our chapter. We need all the input that we can get, your ideas and support. Our chapter will use these funds to provide free educational webinars like the few that we've had in the past with expert guest speakers, documentaries, raffle prizes, support, and continuing education credits. That's on our to-do list. And hopefully one day a weekend meditation retreat post-COVID. We ask that you consider a donation. Any amount would be appreciated. Our donation link is in the chat box. Over the past year, we received feedback that you are interested in discussing journal articles, creating a book club, sharing difficult or interesting case studies, and viewing documentaries while inviting guest lecturers. Tonight, we're so excited to have Ryan Murphy, our treasurer and advanced practice nurse at St. Joseph Health Medical Division of Palliative and Geriatric Medicine in Paterson, to discuss two case studies on the usage of suboxone and ketamine. We will be posting a survey in the chat box for you to complete an evaluation survey. We really need you to complete it and provide us with feedback and ideas for future programs. So now let's review the agenda. Hello, there we go. All right, our chapter meeting will begin with old business, then new business, treasurer and membership reports, our raffle prizes and survey. Then we'll begin with the case studies. So to start off with our old business, minutes from our November 19th were already reviewed and approved, and we will be posting them on our website moving forward. Currently, we're holding elections for the executive board positions of president and treasurer. Members of the Northern New Jersey HPNA chapter were invited to vote, nominate, or run. And Leslie Miller is running for president. Yay. and Ryan Murphy for a second term as our treasurer. They will begin their posts next month for a 2-year term. And I wish them all the luck and appreciate their commitment to move this brand new chapter forward. I am confident that 2022 will be an exciting and successful year. And I have to say for myself, it's been an honor and humbling experience to serve as the president these past years on the steering committee, and then for these short months in chapter status. And I have to say that I've learned so much from the members of the steering committee, and I hold all of you in high regard. Now, on to new business. Recently, I was honored to be selected to participate on HPNA's newly formed Diversity, Equity, Inclusive, and Belonging Task Force. Currently, I'm working on a subgroup to create a diversity, equity, inclusion, and belonging style guide, modeled after the University of Iowa's Diversity, Equity, and Inclusion Style Guide, to attempt to answer common questions and provide thoughtful guidance on topics that may arise when creating or editing content. HPNA strives to create and sustain an equitable and inclusive environment for all staff and members. The ways in which we communicate with and speak to each other and beyond sets the standard for the inclusiveness we aspire to. So now, let me turn it over to Ryan to report on our Treasury and membership committees. Ryan?
Hello, everyone. So for Treasurer report, as a charter chapter, we hold 2 accounts, one specifically for donations, the other for our membership fees. Currently, as of November 30th, our donation account has $221, which is the same as the previous cycle. And our membership account holds $492.57, which is $70 more than the previous cycle, which accounts for the new members that we have accumulated since that time. And which leads me to our membership report. We currently, the Northern New Jersey chapter specifically, has 19 active members, which I believe is up. I think the last meeting we had, we were at 16 or 17. So we're very glad to welcome 2 new members to our ranks this time around.
Great. Now I think, Leslie, you're going to review a few things, right?
Yes, I am going to share with you that for this event, we're going to have a raffle, and we will be raffling off 2 books. The first book is by author Mary Lynn McPherson, Demystifying Opioid Conversion Calculations. And the second book is a great book that I read. I had the opportunity to meet the author a few weeks ago at a physician function that we had at Raritan Bay for Hackensack Meridian Health. Her name is Rana Audish. She wrote a book, In Shock, My Journey from Death to Recovery and the Redemptive Power of Hope. So at the end of this event, we will mention the 2 winners of the raffle.
These 2 case studies. So Ryan?
All right, everyone sees the slides?
Yes.
Looks great. Okay, good. Well, hello again, everyone. I am Ryan Murphy. I'm a nurse practitioner with the Palliative Care Division at St. Joe's in Patterson. I also serve as the treasurer and membership chair here on our Northern New Jersey HPNA chapter. And just to echo what Tacey had said earlier, it's really been a pleasure to be working with this group of people. And so glad to have you guys as colleagues and friends now. And also glad to join you guys tonight to do a little case study presentation. Before I jump in, I'm just wondering if people can start to throw in the chat. I'd love to know what your practice arena is. Are you practicing palliative care? Are you practicing hospice? Are you inpatient, outpatient, community? Just really looking to know, who's in the crowd, and what patient population you guys serve. Outpatient, community, palliative, hospice, doula. I see Kathy Lubliners here, St. Joe's Inpatient Wound and Ostomy Incontinence APN. Hi, Kathy. So I'm glad everyone is here, and I'm hoping that you all can learn something and take something back to your practice. Specifically, tonight we're going to talk about two different drugs, buprenorphine and ketamine. Though you might not be the one directly prescribing or managing, maybe it's something that you can just bring to your program and ask if it's something, a tool that you think would be helpful for your practice. So just disclosures, nothing to disclose. And like Casey said, this is not considered medical advice, so please don't sue me. Thank you so much. So for our two case studies again, the first we are going to do a case that talks about using buprenorphine to manage pain for someone who has concurrent opioid use disorder with a palliative diagnosis as well. So something life-limiting outside of their opioid use disorder. I'll spend, I think, a little bit more time on case study number one. There's a lot of nuance within opioid use disorder. This patient population, specifically within the realm of palliative, is an interest of mine, and certainly something that I see often in my patient population. And then case study two, we'll discuss using ketamine to manage refractory pain for a hospice patient, which is a little bit more straightforward pain management. So like Tacey said earlier, we're going to go through each case study, and then after each one, we'll pause and we'll take questions. But if questions are coming up as we go through the presentation, please drop them in the chat, and they'll be monitored, and then we'll get back to them when it's time to discuss questions. Oops. So through each of these case studies, for both of these drugs, I hope to do these things. I hope to discuss baseline knowledge and use for both of these drugs, how they can be started on different patients, what are some barriers to using them, and really what resources are available to learn more. Myself, I've only been practicing as an NP for 5 years. I've been using these drugs for even less time. So I certainly use them more frequently, I think, than others, and I'm comfortable in doing so, but certainly not an expert and always learning more. So I have some resources that I always go back to that I hope can be useful to you as well. So let's talk about buprenorphine. Is there anyone here you can throw in the chat? Is this a drug that you have come in contact with? Do you prescribe it? Do you know practitioners who prescribe it? Have seen patients on it within your practice? Would love to know if anyone has any familiarity with it. And while you guys are entering the chat, let's just take a look at the drug itself. So the drug class, it's considered a partial opioid agonist. And this label as partial opioid agonist really has to do with its mechanism of action. So buprenorphine has a really high affinity for the mu opioid receptor. And so the mu opioid receptor, again, is classically seen to be the site for opioids to sit and block the pain receptor within the central nervous system. So bup has a really high affinity. It's a really, really strong magnet to that receptor, more so than other opioid drugs. So it will go in, it'll punch anything off, and it'll sit on that receptor. However, it's only a partial agonist because of this effect plateau that it has at higher doses. So once it's stable, once it's sitting on those opioid receptors, it's not going to let anything else in, and it's not going to address pain any further than what it does at its highest form. So then it becomes an antagonist. So once it's on there and it's sitting and it's stable, it's not going to allow any other opioid to be there to help with any other kind of pain management. So there's many forms of bup. most common and what we'll focus on today is the sublingual tab and the buccal patch. However, it does come in a transdermal patch, Butrans, which is more commonly used for, or in pain management realm, the patch is used more commonly. It's a patch that you place actually just once a week. It's on there for 7 days. But today we're going to focus more on the sublingual tab and the buccal tab. Onset of action is about 15 minutes, half-life anywhere from 20 plus to 30 plus hours. And the adverse effects of Bup are pretty much the same as our classic opioids because it is an opioid drug. So we're always worried about constipation, dry mouth. What we're less worried about is the sedation and those types of adverse effects because typically this is only being used in a patient that has, is very opioid tolerant, whether that's because they've been on opioid therapy before or they're using some kind of illicit drug like heroin or other non-prescription drugs. So they're usually very tolerant of opioids by the time they get to Bup. So we're not worried about like first dose sedation with this drug. Good, I'm seeing the chat here. Some providers aren't doing it, have come across other patients but not using it themselves. Some people specifically for detox only. So that's good. So I'm hoping that we can kind of expand that and talk about how it can be used for opioid use disorder and pain management within this patient population. So classically, first and foremost, it is a drug that's used for opioid use disorder. It's an FDA approved for medication-assisted treatment, or MAT, which is any kind of pharmacological intervention to treat substance use disorder. In 2000, with the Data 2000 Act, buprenorphine was actually named the first MAT agent that could be dispensed outside of an opioid treatment program. So classically, we're thinking things like a methadone clinic where patients in opioid use have to present to a clinic on a daily basis, or after they've been a part of the program for a long period of time, they can present every other day, every 3 days, whatever the program allows for. Now this agent, Bup, could be given by primary care clinicians without that daily follow-up. So the hope with that was that it would be expanding, expanding access to this patient population because they didn't have to be a part of a formal opioid use program. And classically, buprenorphine is started for someone in opioid use disorder when they're actively withdrawing from whatever substance that they use. So in a heroin patient, they're actively withdrawing from that heroin, and then they'd be started on this MAT. In the world, you probably have seen buprenorphine within its combo agent of suboxone, which is buprenorphine plus naloxone. Naloxone is Narcan, brand name Narcan. Narcan is a full opioid antagonist, where Bup is the partial agonist, naloxone is the full antagonist. So it's supposed to be, again, another deterrent for use of any other substances on top of this drug, with the thought that with the Bup plus the Narcan, if someone slips and uses heroin even on this drug, there's very, very little chance that they'll feel the effects of that heroin. And a benefit of Bup is because of its effect plateau, there's very little risk for respiratory depression. So other MAT agents like methadone, that's a full agonist, can stack on top of each other. So if you're on methadone and then you use heroin on top of that, you put all those things together, there's a chance that you're going to get sedated and go into respiratory depression and could eventually die. Suboxone, because of that effect plateau and because of naloxone in it as well, there's very little risk that you're going to kind of tip over into that full sedation and respiratory depression. So that's a big bonus of this. There is a waiver required to prescribe this medicine. How you achieve that waiver has actually changed recently within the context of the COVID pandemic. Historically, whether you are an MD or an NP, you had to do a certain level of continuing education to get waivered and be able to prescribe. For MDs, it was 8 hours of continuing ed. Us NPs had to do 24 hours of continuing ed. And by doing that, you would certify that you're allowed to carry a certain amount of these patients on your panel. Now, within COVID, they've now taken that away, where you don't have to do that formal education. You can just apply for your waiver. Any licensed individual provider can apply for a waiver and treat up to 30 active patients on Bupe. Anything more than that, you would have to go back and do that additional training to get access to having prescriptions more than 30 active in the community. Essentially saying, if you have more than 30, you really should have more specific training in that patient population that you're treating. Outside of opioid use disorder, there are indications to use Bupe specifically for pain management. It is an opioid, so there are indications for acute and chronic pain. It goes and sits on the mu opioid receptor, the same as other opioids, so it affects pain the same way. But of course, it's less likely used for a multitude of reasons. You know, before the restrictions were just lifted, you know, who has time to do 24 hours of continuing education credits outside of what we already do to get waivered? Specifically for a pain population, not opioid use population, it's harder to manage pain if you're on Bupe, because again, if you're at that effect, that plateau effect, if you have breakthrough pain above that, if you're using short-acting opioid to try to chase that breakthrough pain, it's going to be hard to achieve that pain relief, because that short-acting opioid is not going to find any opioid receptors to sit on to give pain relief. And patients, you know, particularly, I can say in my population, I don't know about yours, but they know what suboxone is, they know buprenorphine is, they know it's associated with substance use and addiction treatment. So they would say, why the heck are you coming at that with me? You know, are you saying I'm addicted to these drugs? Do I need some kind of addiction treatment? So certainly there's patient resistance as well. But maybe all of that said, maybe this is the perfect agent to treat pain in a subspecialty population. So with that, let's jump into our case, and I'll introduce you to SP. He's a 49-year-old man. He's got a medical history of hypertrophic cardiomyopathy. He had a myomectomy and AICD placement years and years and years ago. And he has opioid use disorder. So he has been using heroin for decades, a pretty impressive amount of heroin every single day. And it has really limited how he can, you know, how he can engage in the healthcare system. What I got to know about him is that he was divorced. He had one son who also had a son, so one son and one grandson. His ex-wife lived out of state, but did stay in touch with him. They had a phone call every once in a while just to check up. You know, by his mouth, he would say, you know, she would call to make sure I wasn't dead. So would check in every once in a while to see, you know, where he was, how he was doing. The son, who lived in New Jersey, had strict boundaries that he was not to be involved with his family, and they did not have any follow-up, which is certainly not uncommon for a substance use patient and the family dynamics. Certainly, dependent people who grew up in that system or you know that environment, if they are lucky and they don't have substance use themselves, you know, it's possible that they have those boundaries and there is that separation, and it can be difficult to kind of bridge that gap. And he was homeless. He had no formal housing as he came to us in the hospital. So for his admission, he presented with shortness of breath, cough. He was hypoxic. Both legs were really, really swollen. He was really weak. He could barely make it into the ED doors. And he was evaluated and essentially admitted for management of acute and chronic heart failure, as well as acute kidney injury on top of chronic kidney disease. And after evaluation and workup, it was decided that he needed an ICU stay for cardiorenal failure. And he was in new, fully blown renal failure requiring replacement therapy. So palliative was consulted, and I'm going to try not to be soapboxy here, but I'm probably going to be, but whatever. I'm talking, so I get to. Palliative was consulted, and it's a totally appropriate consult for my team and our culture and how palliative care is engaged within my system. Why we're consulted is inappropriate, and I'll tell you why. So, he's going through this treatment, he's in the ICU, he's in renal failure, nephrology comes on board and says, we are not offering dialysis to this person. He's non-compliant, he doesn't engage in the healthcare system. Consult palliative comfort measures, we can't do anything about it. So I come in, and this happens all the time. It happens all the time. And I try really hard not to get angry about it. It's a knowledge gap. We have to do better within our own community to do that. But it is a pet peeve because I don't know about you guys, but I'm sure you come into play with other specialists who, you name it, will dialyze or give cancer treatment or do all of these interventions to otherwise clinically very ill people who don't benefit from those things. But then you see someone with substance use disorder and they throw their hands up. They're not going to engage. They're not appropriate for it. So in a kind of backhanded way, I saw the patient. I wrote a note saying, okay, nephrology is not offering dialysis to an otherwise appropriate person. I guess I'm going to transfer to comfort care because they're not being offered this needed medical intervention. And that ruffled some feathers, and eventually they did start dialysis because this is, he has an underlying illness that we're not treating, and then we expect him to follow other medical guidelines or other medical treatment plans, and that's inappropriate. That's our fault. He's here for help, or this patient has presented for help. We have to treat him in his entirety, not just pick and choose what is acceptable and what isn't. We have to meet him with his opioid use disorder and treat that. So needless to say, I do all of that. I'm like, yeah, make people mad, dialyze the guy, he deserves it. And we're also consulted for pain management. So I go in, I'm like, this is who I am, I'm gonna help pain. And he kicks me out right away. Which is also a normal response that we get within this patient population because they don't trust the medical system. Why would they? No other practitioner has ever come into their room and asked them, about their trauma, about their past, about, what's going on, treated their pain and their symptoms as if they're any other patient. These things get held back from them because they have this use disorder. So why would he think I'm any different? I don't know. That it would be silly for him to think I'm automatically the person that, my service is going to help any different. So I don't, when that happens, it's totally normal. I try not to take it personally. I say, listen, I am here to try to help. My line I usually say, which usually it's a hit or miss, but I usually say, me and you, we're already friends, whether you like it or not. So we can skip that middle part of, back and forth, kick me out, and we can just get started. Or we can go do it the hard way, and I'll just keep coming back every day until you realize that I am a friend and we can move forward. So after a couple of visits, it did work out, and he allowed us to be a part of his team. So that's a little outside of the symptom management that we're talking about, but I think it is a really important topic to discuss. And I think definitely we can talk about this thing in other presentations in the future too. Substance use disorder, harm reduction, trauma-informed care, all of these things are super hot topics and really important in our climate right now. So I just, we can talk about those things, I think, in a future presentation as well. So his pain presentation, once I was able to get in there and really start my assessment, he had whole body aches, definitely secondary to withdrawing. He actively used heroin the day he came into the hospital. So every day after that, he's going to start to withdraw. Bilateral lower extremity pain. He had weeping edema, really terrible, before he started to get dialyzed and get some of that fluid off. And then really bad chest pain because he was so short of breath. He was really fighting for that air, and on and off on BiPAP to give him that extra support because he was really struggling. He was in such fluid overload that he was really drowning. So, he was open about the fact that he was a heroin addict, and he had engaged in MAT previously. He was on methadone. He wasn't currently a candidate to restart that because he had a prolonged QTC, which was above 500, which is an indication or a contraindication to using methadone because it can prolong your QTC, and especially if you're already starting above 500, there is a risk to slip into torsades, which he was really bummed about because he wanted the methadone. It worked really well for him in the past, and he was really interested in starting it again, but it wasn't something that we could offer. So I said, let's try Bupe. Have you ever used suboxone before? And he said, I can't do it because classically, like we had talked about, when you start buprenorphine, you have to let the body withdraw and you have to be in a certain level of withdrawal before you can initiate buprenorphine. And we'll talk about that more later, but long story short, if I give him Bupe too early, I'm going to precipitate an even worse withdrawal because that Bupe's going to go in there. It's going to punch right onto those receptors. It's going to kick off all the heroin super fast and make his withdrawal much worse and much faster. So he's tried it. He said, I try to hold on to, I try to stay as long as I can, but they ask me to withdraw and then I have to go. And he had so many other presentations that were similar in the past that he had to leave AMA because his withdrawal was just intolerable. He had to go use to stabilize himself. So couldn't use methadone. He was refusing buprenorphine. What do we do? Could I possibly use a full agonist opioid? Meaning, am I going to give this guy morphine? Am I going to give him Dilaudid? Am I going to do that through the IV? Am I going to give that to someone with opioid use disorder who's actively using IV drugs on the street? What do we think? Throw some answers in the chat. Because this is a question all the time, right? It comes up. Is it safe to use a drug like that on someone who is addicted? Leslie Miller says definitely. She's confident. Is anyone questioning? You're going to prescribe high dose Dilaudid to a heroin addict? Good. Yeah, I see a couple of answers, and like Leslie said, he's already addicted. Convince him to use the Bupe. Marianne brings up a really good point we'll talk about. It's such a common issue. History of substance abuse and pain management won't touch them because of their tolerance. So essentially the answer you guys have got there, which is great. Yes. Even if someone has opioid use disorder and they're actively using heroin the day they come into the hospital, if they have pain or if they have withdrawal symptoms and we can't use any other thing, we use full opioid agonists. We're going to give them Dilaudid, we're going to give them morphine. And it's kind of akin to what Leslie said in the chat. My boss, my director, Dr. Abiger, who's a genius, she said, what are we going to do? Is he going to get more addicted? He's addicted to heroin. We're not going to change that. And it's such a common issue that we get. And the interns, so St. Joe's is a teaching hospital. We have a residency program. The interns, or I think all the residents, but then they ask the first year residents to say, call palliative, or are we supposed to do this? Can we give this kind of drug to someone who has an opioid use disorder? Or the nurses will call me and be like, this guy keeps asking for his Dilaudid. I'm like, Yes, he does, because he's in active withdrawal from opioids, and we need to give him opioids to stabilize him. So again, even medical assisted treatment, methadone, buprenorphine, these are opioids. We're giving people opioids to manage their opioid use disorder. So in any other clinical scenarios where we can't give them the things that we classically use for that type of treatment, we give them full agonist opioids. So I think that's really where I get off my soapbox for the evening. I'm sorry if that came off preachy or anything like that. I feel passionate about it, and I feel excited about educating on that piece, because I think it's an underserved population, and it's not their fault that they're underserved. It's our fault. It's our medical industrial complex that is not set up to care for these patients and these people. And then we expect them to do things that they just physically, mentally, emotionally cannot do because they have a disease that we're not treating. So, okay, I think I'm off my soapbox. So yes, what we did, we used full agonist opioid to address his pain and his opioid use disorder withdrawals. So essentially, I had to get him on a dilaudid PCA. Marianne had mentioned that it's hard to do pain management on someone who has substance use disorder because their body is so tolerant, which is very likely that you're going to need higher doses to really catch their pain. So I think I undershot this guy for the first maybe 12 to 24 hours trying to keep him on a dilaudid PCA. Eventually, I think I got him stable with 3 milligram boluses of IV dilaudid every 15 minutes as needed, delivered from the PCA. He hung there for a couple of days. And then once he was stable, we were able to take a step down. I came down to 2 milligrams. And then he was still remained stable. I came down to 1 milligram. And it allowed him to stay in the bed. He stayed in the hospital. He got his Shiley placed with surgery. I'm sorry, his, someone put it in the chat. What am I thinking of? You have to plant a blank to do dialysis. Yeah, dialysis cath, but fistula, shunt fistula. Thank you so much. See, I knew that. I was just asking for participation. So thank you. So he got a fistula placed with surgery. He started in dialysis. He lost like a bajillion pounds of fluid. He could breathe. He was off the BiPAP. He was engaging. He was super pissed off because he was on a renal diet. And he's like, I'm on the street. I live on the street and I use heroin, but I can't have salts. This is ridiculous. But you got to know him as a person because he wasn't agitated and he was settled, and we treated his needs. So he was able to fully engage in the medical care for his other illnesses. However, the dilaudid PCA that was stabilizing him was really limiting his discharge. So he got to the point where he was actually medically cleared. He was ready for discharge, but nothing else, no rehab facility or nursing facility could accommodate the PCA. So went back to him and I said, listen, there's really only one way out the door at this point. It's live here with your PCA, or let's get you over to buprenorphine and we'll get you out the door. And he disliked being admitted much more than he disliked the idea of buprenorphine. So that's what we did. So let's talk about how you can start buprenorphine on someone like this. So we had talked earlier about the classic withdrawal initiation, which is based on use of the COW scale, the clinical opioid withdrawal scale. I believe it's a scale that's ranked from 0 to 36 or something like that. And it takes into account all kind of withdrawal symptoms, sweating, pupils, agitation, goose flesh, all of these things that you're going to see physically on someone as they withdraw. And after they hit a moderate score, then you can start to initiate the bup. Again, because what we talked about earlier, if you give it too early, you're going to precipitate that withdrawal. So when you think it's that time, you start with a 2 or 4 milligram sublingual tablet. And unfortunately, it's kind of like a watch and wait type of thing. And you're giving it to this person kind of with like a shaking hand saying like, this is going to make it better or it's going to make it worse. I don't know. And I've certainly seen people, even when you think they're moderately withdrawing, you give them bupe, it makes their withdrawal worse and faster. And if that happens, you just keep dosing them every hour or 2 hours and say, you know, keep telling and reassuring them, this sucks, this sucks, this sucks. There is going to be a time where you're stable. And then all of a sudden they're going to be like, oh, okay, I'm even. I feel okay. And once you hit that point, then you're going to start to increase your dose. And ultimately, your target maintenance dose for specifically opioid use disorder is 8 milligrams twice a day, and that's the sublingual tablet. If you're using it for pain management, a lot of literature says go up to 8 milligrams 3 times a day. So that was kind of my agreement with him when we did start was, I don't know where we're going to land, but my first target is 8 twice a day. And then if you're still in pain, then we can go up to 3 times a day. But this was the type of initiation that he was not interested in. He didn't want to do. So what is coming out in the science and what St. Joe's is starting to do is called microdosing. So microdosing means keeping the full opioid agonist running. So keeping his dilaudid PCA running while giving him tiny, tiny, tiny bits of buprenorphine in a gradual manner. And then the bupe kind of sneaks in there and will take over those opioid receptors very, very slowly, very, very slowly. And then all of a sudden they're at steady state with the bupe. And the full agonist opioid is actually not doing anything. So it avoids that withdrawal completely. And they can keep using their full agonist opioid alongside of it. So once the bupe is at steady state, then you can just stop the full agonist opioid altogether, just all in one, because the bupe is at steady state and it's keeping all of those receptors nice and saturated. So this is the policy that we use. And Marianne, maybe if you did download, just because I don't think I'll be able to do it now, if you can drop the St. Joe's Hospital policy for microdosing buprenorphine.
Okay.
If not, then I'll drop everything at the end. But I do have the formal St. Joe's policy, which was created by Dr. Alexis LaPietra. She at St. Joe's, she's our pain and addiction medicine chief, and a great advocate and a great educator who does a lot of work to build these policies. And I spoke to her and she has no problem with these policies being shared with you guys too. So, so this is what we do. It does take time, right? Because you have to go slowly, step by step, to avoid that precipitated withdrawal. So you'll see on day 1, it's 450 mics of the buccal film. So the brand name is Belbuca. It's a tiny, tiny, tiny patch that actually goes on the inside of the cheek and will stick to the inside of the cheek. And then within 30 minutes will dissolve. So you give it to your patient, you put it on their cheek. Thank you, Marianne. It's inside their cheek.
Is that the right one? No, this is ketamine, right?
No, there should be one for bupe.
Let me find it. Okay.
That's fine. Spoiler alert, we're talking about ketamine next. So the Belbuca, again, goes inside the cheek. It'll sit there for about 30 minutes and then totally dissolve. And we just build on that. So day 2 is we're doing that twice a day. Day 3, then we're going to the sublingual tablet, which again is a small tab. It goes under the tongue, and we want it to fully dissolve sublingually. We don't want the patient to swallow the pill whole. If they swallow it whole, they will not be getting the effects. And I've had patients do that where I own that user error on my part, not to fully, make sure I'm very clear. You cannot swallow this, because if they do, they won't feel the effects and they'll still go into withdrawal. So then you just build on that dose of the sublingual tablet until eventually you're at that target dose of 8 milligrams BID. And then on that same day, then you can just discontinue the full agonist opioid, because they should be at steady state. This is also a really great way to make enemies in your long-term stay board or anyone who is like monitoring length of stay. definitely get a couple of calls every time I do this, and they say, "Can you do this outpatient?" And I say, "No, thank you so much." So that's what we did. We successfully microdosed him onto the buprenorphine. He was actually, for his use disorder and his pain, was very comfortable on the 8 milligram twice a day, but we left it open to say, we can do that 3 times a day. If your pain escalates or if anything changes, we can do that. We got him linked into a peer counselor from a local opioid use disorder program. We're fortunate to have pretty good relationships with those programs in our community. And eventually he was transferred to rehab. And since that time, he's kind of bounced back and forth between rehab and SAR for the CHF and renal failure, but ultimately he has stayed engaged in the medical system and stayed really well controlled on the bup, which I think is fortunate. So limitations to using this drug, obviously provider knowledge. It's not something that everyone is comfortable with. Again, like we said, who has time to kind of go through this program, even though now any LIP can apply for their waiver. There is pharmacy discrepancy. If technically, legally, anyone, even without their X waiver, can prescribe this into the community if it's for specifically pain management. If it's for opioid use disorder as well, then you need to be X waivered. But anyone, any practitioner should be able to prescribe this for pain management. However, you send a bup prescription to any local pharmacy, they're going to say, "What the heck do you think you're trying to do?" And usually they won't do it unless you are X waivered, even though you're legally allowed to do it. So again, the patient reluctance, and we talked about that as a limitation. But it's really a knowledge gap. I think that's really what it comes down to on everyone's account. So I think these are really great resources to use in the future. I mean, I go back to them constantly, and I think that you guys might find some interesting info on there too. So SAMHSA, Substance Abuse and Mental Health Services Administration, they are the system that you can apply for your waiver for. I applied for mine, I don't even know when, months ago. But I don't think I heard back in the context of COVID. I did do the full training and everything. But we can actually, another thing too that you can check with your facility is if you're inpatient providers are allowed to prescribe it regardless of being X waivered. So, but that's something that might be institution based that you have to check your policy. And then the American Psychiatric Nurses Association, this whole CEU training to get waivered is completely free. They offer it free all 24 hours. And the training is it's really in depth. And I think it's a really good resource too. So if anyone is interested in doing the waiver, I would just go right there and do the free online training right there. Okay, any questions? Let's pause. Any questions on the buprenorphine case? Do you want me to scroll through, or Marianne, you want to call them out for me?
Yes. So there were a few questions. For example, how do you convince the patient to use the medication, especially as as you said, they often already think of it with a big negative connotation.
Yeah, I mean, all you could do, I think the answer to that question really lies outside of any drug or any kind of agenda. It's just about building a relationship with them. And if there's any patient population that I've worked with that is a no BS population, it's substance use disorder patients. They don't want the frilly, they don't want the lies. They want to be straightforward. They want to trust you. They want consistency, because that's all the things that they lack in other social settings. So it's really just about building that rapport, and then you partner with them. And it's all of this type of care really goes back to the fact that yes, I have a medical degree or, a nursing degree that allows me to prescribe medicine. I have this knowledge base. This person is an expert in their own life, in their own world. If I was living the way that they were living, I would be dead in 2 minutes. They are survivors. They are experts in how to navigate their community. So I can't come in like, on a high horse and saying, this is the way to do it. That's not about it. And say, listen, this is what I know. This is what I can offer. What do you think? And just really building that trust.
Good. How about when you have to, when the patient leaves, and how do they get the medication out, patient? And how long do you or does one prescribe until they get into a outpatient treatment center?
Great question. So it is something you're going to want to be connecting with your case management team. Know that flow as soon as you're starting the drug. So you want to know where are they going to get it in the outpatient world if it's not from you. If your service doesn't have a provider that can do that on a long-term basis, make it your responsibility to find where can they be partnered and where is it realistic that they are going to get that drug. So this individual was going to a rehab, and we had to be matching him with a rehab that had a clinician that was comfortable and able to provide this to him on a continued basis. But if someone's going home into the community, you're going to have to figure that out, what that bridge is. My service, we have a doc, and as soon as I'm X waiver, as soon as it comes through, we're comfortable doing it in the context of use disorder plus pain management. We can manage those patients ourselves. But if your service doesn't have that person, you're going to want to reach out to the MAT programs in your community and make sure that they're linked in before they go anywhere.
There was one more question, I think from Adrian. What I really think is I didn't really get the question, Adrian. Let's see if I got it. Where is it? What did you do with the wife, son, and the grandson?
Did you do anything with them? What did you do with that information?
It's a great question. I had a relationship with his wife. I spoke to her over the phone a couple of times. I kept her involved with, with this decision of getting him on the opioid, getting him on the Bup. I never met him never met her in person. I think she's in California and stays there. That's where her full life is. So spoke to her a few times with him, a few times without him, as support for her, saying, sometimes it can be really tough to be engaged, married or involved with someone who has this program, making sure she has the resources she needs or support she feels like she needs. And the son never came up again, to be honest. I didn't push any kind of meeting with them or, it's not necessarily a need that the patient made known. He didn't really say that he was looking to engage with his son in that way. So that really didn't come up again. Good question.
Outstanding.
Anything else on Bup? Okay, well then, let's just take a breath, a focus reset. I always like to do this in between case studies because I feel like the medications and the info can get bogged down. So totally unrelated, but very important poll question that I have a reason why I'm asking. Brownies should have option A, cake-like consistency, or B, fudge-like consistency. And there is, C, both. I don't know a recipe that does both, but that's interesting that you're making your own answer.
Fudge-like and cake-like.
There is a very strong correct answer. Okay. Good. I see some A's. All of you A's are
Crumbly
wrong.
on the inside. Janine's right.
Cake-like, no, Leslie Miller.
Crunchy on the edges. Inside. Okay.
Brownies should be absolutely fudgy. They should not have to be. If I want a chocolate cake, I would have chocolate cake. A brownie should be fudgy. And I say this because, Marianne, if you can drop in the Dropbox.
Here it comes.
We can offer you CEUs, but I'm offering you a
Hi.
BE, a baking
the
education
one?
course, a baking education unit with the recipe of my favorite brownie recipe. Super fudgy, and that is the correct answer. Kathy, cake-like. No. Good, I'm glad there's debate. I was afraid people were just gonna all agree. Well, for those of you who say brownie should be cake-like, try the recipe, see how it goes, and then get back to me if you're converted or not. Okay. All right, so I have another case study. Again, like I said, it's a little more straightforward pain management stuff. It is, there's not too much nuance to it, but we'll go through it. So let's talk about ketamine. Before we jump in, is ketamine a drug that people are using in their institutions, or have you seen it used? Seeing a couple head nods. Janine's using it for palliative sedation. Melissa, not yet. Jeanette, yes. Good. Okay. Some no's. So again, it's kind of spread. And some more on the sedation side rather than pain management. So that's good. I'm hoping we can come together and talk about your experiences too. So ketamine, drug class, it's a general anesthetic, and historically it was used as such. It was used back in the day, very higher doses to create sedation for surgery or procedures. It does so by creating that sedation or dissociation directly within the central nervous system. It comes in many different formulations. There's IV, sub-Q, oral, intranasal. This case, we're going to focus on the IV. Onset of action is within 30 seconds, and half-life is 10 to 15 minutes. So this is a super on quick, off quick drug, which comes into play of how we use it. And the adverse effects really fall into this category of creating dissociation, a dreamlike state, vivid imagery that can often be distressing. And it's kind of why ketamine fell out of practice within the sedation world as their leading drug. They use it in some cases, but there are other things that don't necessarily cause this negative dissociation. How it's thought to help with pain management. It's thought to have some kind of effect on the NMDA receptor, which alongside the mu receptor, it seemed to have some kind of factor in pain and pain control. So if there is peripheral or chronic pain, the neurotransmitter glutamate sits on the NMDA receptor and creates that that centralized sensation of pain. And ketamine is seen to block that receptor and disrupting that pain signal when we use it that way. Non-sedation uses, again, are acute pain crisis. It can be used for opioid-induced hyperalgesia to kind of reset that, resetting high opioid tolerance. It's a non-opioid adjuvant for pain or refractory pain that continues despite use of opioids. And there's a new body of literature coming out supporting the use of ketamine for depression and other serious mental illnesses. I certainly have another sub-patient population of palliative diagnoses plus a serious mental illness, whether that be schizophrenia, bipolar depression, something like that. And I have used ketamine infusions on that population specifically for pain management or for acute pain. But then they do tell me, they come back and say, you know what, my mood has been much different for the last few days after the ketamine infusion. So I think there is something to it. And I'm starting to see more and more infusion clinics pop up within different communities. They're usually private pay, places where you can get fluids or supplements, but they're adding ketamine to their menus too. So you can go and privately pay for a ketamine infusion. So I think there's going to be a bigger role for that as well. So our case, I'll introduce you to DP. She was a 64-year-old woman. She had history of hypertension, hyperlipidemia, and her palliative diagnosis was really her metastatic colon cancer with retroperitoneal adenopathy. And she has gone through multiple lines of systemic therapy, and she had declined surgery always. She said, whatever happens, I don't want to be cut into, and I don't want to, pieces to be removed. That's my limit. Socially, what I got to learn about her, she had 3 children, 2 were living. A daughter actually died of breast cancer, I think within the last 10 years. It wasn't a topic that we engaged with that often, if I'm honest. I think it brought a lot of trauma and distress to think about her daughter's death on top of her own illness. One son lived down in Florida, and she lived with the other son. She was never married, so her children, especially her son, who she lived with, was her real support system. We have been involved with her care for a while throughout her clinical history. She was typically admitted to our satellite campus, our Wayne Hospital, where we have Palliative has a nurse practitioner there who would see her for pain management typically. Oh, sorry, my dog. And when she was at Wayne, she would get the pain management, and then she would be referred to our outpatient clinic, which is typically run by me, and also our director, Dr. Aberger. And she would follow with me every once in a while. Not enough where I was regularly prescribing her pain medicine. She would definitely, fall off the list and, have pain crises that would eventually bring her back into the hospital. And I just never had that continuum of care with her that really gave her the best pain management. So really, we engaged with her mostly while she was inpatient. And while she was there, we also engaged with goals of care towards the end of her disease-directed therapy, which led to a hospice transition. So we first transitioned her to inpatient hospice, and then eventually got her home on home hospice. So as far as her pain goes, she had severe abdominal pain, because of her colon cancer. It banded to her low back with some intermittent radiation to her lower extremities. She was maintained on a complex regimen at home through our hospice agency, but steadily her pain needs really increased, and it became too much to manage in the home. So you can see here, this was the regimen that she was on at home. She was on methadone, 40 milligrams, PO 3 times a day. She was on fentanyl 400 mics an hour with patches. So that's 4 100 microgram patches that she was wearing. And a dilaudid PSA, so 7.5 milligrams an hour, just constantly running through a basal rate, and then 4 milligram bolus every 10 minutes as needed. So extensive opioid that she was using in the home. And eventually it just became after her pain was breaking through that, the hospice team said, you know what, we really got to get her into inpatient. We can't manage this at home anymore. So they did that. They brought her into the hospital. You'll see here, they kept her on her home regimen, and then slowly started to add a fentanyl drip as well, and started to escalate that. And on top of everything she was already on at home, she was on a fentanyl 450 mic per hour IV drip, with an additional 0.5 milligram of Ativan IV drip as well. So, and all of this, her pain was refractory. It was still not being well controlled. The nurses would call overnight saying, she's crying in pain. We don't know what to do. Patient was in distress. Nursing was in distress. Hospice was in distress. So I actually worked very closely with the hospice director. So she consulted palliative to start a ketamine infusion. So again, we're using ketamine for this patient who has opioid refractory, chronic, intractable pain, acute pain on top of that, within the last weeks and months to her life. So we need something else that's going to kind of break that barrier. This ketamine initiation, which I think Marianne already shared with you, but if you want to share it again, Marianne, you'll see the ketamine St. Joe's policy, for end of life is the same as our emergency department's acute pain policy use of ketamine. And that's really born out of our ALTO program at St. Joe's. Essentially, it's a whole procedure and a whole effort to use alternative drugs other than opioids to treat acute pain within an ED setting. And we can kind of adopt some of those policies within our patient population as well. So this is a weight-based initiation, and I swear to you, this patient was 100 kilograms on the dot. And I couldn't have made that up. And this was honestly the first time I had done this for a patient in this population, which just made the math super great. So how we start ketamine, we leave everything else running, everything she's on stays the same, and then we start the ketamine. We start with a 0.3 mg per kg bolus over 10 minutes. So for her, that was 30 milligrams over 10 minutes. And then it switches to 1 milligram, 0.1 mg per kg per hour infusion. So that's 10 milligrams an hour. And that bolus, the hope of that bolus is to break that pain cycle, really give them a good dose of ketamine so we can kind of catch up on that pain. And then the infusion comes in and kind of evens her out in the back end. I will say that she did kind of experience that adverse effect of dissociation when we did bolus her. So this was the same week that Jeff Bezos took his little trip to space, or whatever he did, whatever billionaires do in their fun time. And I'm a millennial, and as a millennial, I don't know if you know, there's a requirement that you have to post a certain amount of things on social media, otherwise you're no longer considered a millennial. So I posted on Twitter that yes, he went to space, but this patient, when I started her ketamine drip with the bolus, she dissociated and she said out loud, I'm on the moon, I'm on the moon, I'm circling the moon. And then after that bolus kind of wore out, then she came back to Earth. So that dissociation, the few patients that I've done this in, even before being at St. Joe's, being that feeling of weightlessness, that dissociation, oftentimes make people think that they're in space. So that's not the first time that I've heard that. So she dissociated, she went to the moon, she came back. It was slightly distressing for her to feel like that. She told me she felt nervous, she felt uncomfortable. After that, there was still a period of time where she was confused. And she started talking about her childhood, like she was looking at friends of hers in her childhood. And then eventually she evened out after that. So you'll see here, again, this is all of her starting drugs, the methadone, fentanyl, patches, and drip, the dilaudid PCA, and the Ativan drip. Again, that's how I initiated the ketamine. And immediately as I did that, I decreased the fentanyl to 200 mics per hour in the IV. Because ketamine is so fast acting, we're going to see changes and we're going to expect to have to decrease drugs as soon as we can. So she was at 450. I cut her all the way down to 200. So more than a 50% decrease. And we held her there for a couple of hours at those doses. So we continue the drip itself over a period of 72 hours with kind of every 8 hour, or shorter than that, 4 to 8 hour check-ins to see how she was doing. If she was stable, if her pain was well controlled, I took another chunk down. And what we wanted to do first was just let's get that fentanyl drip off completely. that was the last thing to be added. Let's try to even everything out. Let's try to get the that down. So I kept having that or taking big chunks of that off. Once that was completely off and she was still doing well, pain was controlled, let's try to keep going. So then we take chunks away from any other agent that she's on. So the easiest for her was the dilaudid IV that she was on through the PCA. And you do that for as long as you're comfortable, and with the systematic approach of let's try to get as much opioid down as possible with pain still being stable. So it's not going to be a cure-all. She's not going to get off opioid altogether, but let's go down as far as we can until pain is stable. And once we want to come off, once we think her pain is stable, it's probably not going to get better than where it is. Her opioid doses are now reasonable again. Then we can discontinue the ketamine pretty quickly, again, because it's out of the system. You know, it has a half-life of a half hour, so it's going to be out quick. So cut it in half in 4 to 6 hours, evaluate. You can cut it in half again or just DC, depending on what your doses are, what you're comfortable with. But moral of the story is you'll build a policy that says, once you're done using it, you can really get it off pretty quickly. So again, this is a side-by-side of where we started and then where we ended. So her ending dose, her methadone stayed the same. Her fentanyl patches stayed the same. But now her dilaudid PCA was down to 3 milligram an hour basal with a 2 milligram bolus every 10 minutes as needed. So we were able to completely take off the extra fentanyl IV drip that she used inpatient. She was comfortable enough to discontinue the Ativan drip. And then we took a nice chunk off the dilaudid PCA again, where, you know, home hospice was saying, okay, this is, you know, her pain is managed. She's comfortable. These doses are tolerable for us in the community. Let's get her back home where she really wanted to be. So that's what they did. They brought her back home. Unfortunately, the same cycle happened a couple of times where we would get her home. She'd be stable for a period of time. Her pain needs would escalate. She'd be brought back into the inpatient hospice. We did repeat ketamine infusions on her and went back and forth a couple of times. The only difference in the other ketamine infusions, depending on how her pain was acutely, if she was kind of using a lot of this drug, but her pain was okay in bed, then we wouldn't bolus her because it did, you know, create that distress and dissociation, and we would just initiate that that hourly drip and do the same thing. And then again, this cycle kind of happened, and it got to the point where she was admitted to inpatient hospice, and she really did start to actively die. And we had the conversation with her son and say, listen, you know, I don't know if it's safe to get her home. So she died with us on inpatient hospice. And the son, you know, I think the hope was always that she would die at home. But I think her needs were great, and it would have been hard to do that. So the son was very comfortable with that, you know, when the time came. Limitations to using this drug, again, provider knowledge. It's just not something that's always taught. It's not something that's promoted in different institutions. So there's a lot of learning that has to be done. I know for us, it was a barrier was trying to create the hospital policy that allowed us to do this. And a lot of different people have to be at that table having that conversation: administration, pharmacy, nursing. You know, they had to create the policy that said, you know, patients under hospice or comfort measures can use this at end of life for pain management. And another limiting factor is that this is typically something done specifically on an inpatient basis, not necessarily something that we could offer in the community. Other formulations can be used more easily in the community. I know the intranasal spray, you know, is easily used in a home hospice setting, but I don't think that there's any literature to say that just those intermittent dosings of what we can do at home would do anything to help kind of alleviate this chronic pain or be able to reset the opioids the way that we were able to do here. I think I saw Marianne post this in the chat. I just left one article as a start for resources for you guys. I think it's a really inclusive article, specifically for chronic pain management within the cancer population, which a lot of pain management literature really starts in cancer and then goes elsewhere. So I found this article really helpful. And then again, I think Marianne can share if she hadn't already, the ketamine policy from St. Joe's and Dr. LaPietra. Both of those can be guides for you. Okay, ketamine questions? Marianne, I'll wait for you to call them out.
Oh, they're on mute. Okay, so we have got here, at what point would you have done palliative sedation?
That's a great question.
What is palliative sedation also?
Yeah, so palliative sedation is an intervention when someone's symptom burden is so refractory to anything that we can offer them. Essentially, they have to be sedated in order to be comfortable. And I don't think we were far off with her. I will share that St. Joe's as an institution, I don't think we have any formal policy to say we're engaging in palliative sedation. If we are ever doing it, it's just that we're doing it or not doing it, depending on who's watching this recorded video. So I don't think we have any formal protocol to do that. But certainly if what we did with the ketamine didn't work, I think our next avenue would be the Ativan drip or other sedating meds. Just get those on board in a continuous way and titrate until she's comfortable.
Okay. What are the qualifications for palliative care?
The qualifications to be seen by our service?
Yeah.
So our services is we engage with any patient who has any kind of chronic life-threatening or life-limiting illness. We're engaged at every point of their disease trajectory. To do pain management, their pain has to be thought to be derived from that life-limiting illness. So not necessarily chronic pain or acute pain from other causes like a motor vehicle accident or something like that, or sports injury or something like that. So we'll engage with patients who have those life-limiting illnesses that need support, goals of care, or if they have pain and they fall into that patient population, we can see them for pain management.
Can a ketamine infusion be part of hospice care at home or only in a facility?
In our practice, it's just done in inpatient right now. Logistically, I'm sure it can be done. But I think the thought process is if someone's escalating, their pain needs are escalating to the point where they need a ketamine drip, likely they meet criteria for inpatient management. But yeah, it's only something that we would offer inpatient at this point.
How about inpatient payment in regards to hospice? How long can they stay inpatient in regards to payment? If they're, because I know there's like the respite, 2 weeks. Yeah.
Great question. It's outside of my wheelhouse of expertise. Certainly there's other people on my interdisciplinary team that can handle that part, but from my limited knowledge, as long as we can certify that your symptom burden cannot be successfully controlled in the community, whether that's a nursing facility or your private home, if we can't control you there, you're going to be covered inpatient.
I think there's a time, maybe 2 weeks respite. I'm not sure.
I don't know. Yeah, I don't know that we've ever put that limit on it. I think this patient herself was above that 2 week at the end. I think her last stay was relatively long.
The general inpatient benefit, I
Mhm.
could answer that. The
Okay.
general inpatient benefit for hospice is dependent on the hospice that's providing the inpatient hospice. And there has to be very strong documentation that you're tweaking or titrating medication. If the patient is stable on a certain dose, then the hospice will ask, and the hospital will be asking for a discharge plan. Respite is typically per cert period, I believe 5 days per certification for hospice.
Thank you.
Yeah, and I'm seeing in the chat here. Yeah, this patient, the case we were talking about, when she was back in the hospital with hospice, she met criteria for GIP or inpatient hospice, and remained under that benefit at the acute inpatient level.
Brian, have you had experience with the microdosing of suboxone, and how successful was it?
Yeah, so the case that we talked about today, that was microdosed.
That he was microdosed.
And essentially, that's really all we do now, especially within our patient population, because whether it's for pain management or substance use, they have some level of opioid in their system. So now we have this way of controlling them without that withdrawal, which can be really nasty. And it's one of the leading things that causes, this patient population to AMA. Because if we don't keep them stable, they know how to get stable. They'll go into the community and use the drugs. So that's really typically all we do for this patient population now, with that overlap, if they have opioid in their system. And it's effective. I have, through the microdosing protocol, I have not seen anyone fail or go into precipitated withdrawal or anything like that.
Has anyone used ketamine PO oral? I was working at a hospice residence in New York City, maybe about a decade ago, and we used ketamine PO for unmanaged symptom of pain. Has anyone used that?
I had in my fellowship year, so I did hospice and palliative fellowship at Memorial Sloan Kettering in Manhattan. And they had a different initiation protocol, but similar thought process to their ketamine infusions. And we had a couple patients that during that titration down period of ketamine, their symptoms just became refractory immediately. So we dosed them on PO ketamine. Again, I don't know if it was like the same amount PO that they were getting in the IV, but we would give it to them a few times a day, and they were able to manage in the community.
Yeah, my patient we ended up putting him on palliative sedation eventually. Yeah, it was a lot of pain.
That's another great topic I think that we can explore.
Thank you very much, Ryan. This was very educational. You should
Amazing.
see the comments
Phenomenal.
in the chat.
Oh, good. I'm glad. You know what I didn't do? I didn't really include my contact information. Let me just open up my chat. I'll just drop my private, my personal email address. And then this is the ACHPN Gmail address that I also monitor too. So if anyone has any other questions or comments, feel free to reach out that way.
Thank you again, Ryan. And I think, Melissa, you're up next.
Yeah, so, well, I would like to thank everyone who attended this webinar, and thank you very much, Ryan, for an excellent presentation. We all learned a lot from your presentation. That was an excellent presentation. So, we all aspire and strive to adhere to the clinical practice guidelines for quality palliative care. And certainly this presentation adheres to giving our patients domain 2, which is the physical aspect of care, to relieve all the suffering and improve quality of life as defined by the patient and the family. So thank you very much again, Ryan, for this excellent presentation. So just a reminder, we dropped the link for our donation. Hopefully, you know, any amount will help us so that we'll be able to give you this type of presentation free of charge. But if you can help us in any way with our donation, that will be greatly appreciated. There is a Survey Monkey that is also in our chat. If you have any kind of suggestions, recommendations for our next presentation, that will be greatly appreciated. If there's something that's really bothering you to learn about, that would be greatly appreciated if you can fill out the Survey Monkey. We are going to continue with Zoom now that the numbers for COVID is rising again. So for next year, our goal is to remain giving you, presenting you all these different topics via Zoom. And our next chapter meeting, quarterly meeting, is March 10th of 2022. And we will send you an email as to whichever topic we're going to present. If you can just fill out the Survey Monkey so we know which topics you would like, that would be greatly appreciated. Again, thank you very much to all those who attended. I hope you learned a lot of things from our great presenter, Ryan. Tacy, do you have any other things to say?
Who won the raffle? Who won the raffle?
Oh, yes, I'm sorry, yes. So, drum roll. Brianna Cabelli won the Marilyn McPherson's Demystifying Opioid Conversion. And Janine Goulet won the In Shock by Rana Aldrich. So if you can send us your address so we can send you the books. You can drop them to either email from Ryan or put it in the chat box, but I think email to the Northern New Jersey Gmail would be greatly appreciated. And if you can take a picture, once you receive the book, if you can take a picture with you so we can post it in our website, that would be great.
Definitely will.
Selfie.
Thank you.
Thank you very much again.
Thank you, Ryan. That was a great presentation.
Thanks,
Fantastic,
everyone.
amazing.
Thank you for
It was
letting me
nice
ramble.
meeting everyone.
Yeah.